Today we will discuss a normal ECG. If you want to analyze an abnormal ECG, first you should know what a normal ECG is and what are the patterns of normal ECG to analyze the P wave, QRS, everything in a sequence. You have to identify a normal ECG first. So that's why this session on a normal ECG has been included. This is a 12-lead ECG. The limb leads lead 1, lead 2, lead 3, augmented limb leads AVR, AVL and AVF, and the chest leads V1 to V6. In addition, we have a rhythm strip. This is a page writer which has recorded all leads simultaneously so that each beat will come in all the leads. It is very useful for rhythm analysis, for comparing P wave QRS in different leads. And when you analyze the ECG, first you have to look at the standardization, which has not come in this ECG because it has gone beyond the screen. And then you start sequentially with P wave, PR segment, PR interval, QRS, ST segment, T wave, and this is the TP segment. Now we look at the P waves. P waves are positive in lead 1, lead 2 and AVF. That is a normal sinus P wave. When the activation spreads from the sinus node downwards, P waves will be upright in the inferior leads 2, 3 and AVF. And since it is from the right atrium downwards and to the left atrium, it will be upright in lead 1 also. So that is how you recognize a normal P wave. Then width of the P wave should be looked at. Normal P wave has a width less than 2.5 millimeter. If it is more than 2.5 millimeter, it will be suggesting left atrial enlargement. Then you will look at the height of the P wave. It should also be less than 2.5 millimeter. If it is more than that, it will be indicating right atrial enlargement. If both width and height are increased, it will be biatrial enlargement. Similarly, we will look at the negative component of the P wave in V1. Here you can see a very small positive component followed by a very small negative component. That's a normal pattern. If the initial component becomes tall and peaked, then it will be right atrial enlargement. If the negative component becomes prominent and broad, that will be left atrial enlargement. If both together are present, then it will be biatrial enlargement. Then the PR interval. PR interval is from the onset of P wave to the onset of the QRS complex. PR interval normal upper limit is 200 milliseconds, that is 5 divisions. Lower limit is usually 3 divisions, 120 milliseconds. PR segment is usually isoelectric. If it is depressed, it could be either due to atrial infarction or pericarditis. PR segment deviations occur in atrial infarction and pericarditis. A minimal depression of downsloping nature of the PR interval or rather PR segment can be there due to the atrial repolarization wave or TA wave. P wave is the atrial depolarization wave. Normally you are not seeing an obvious negative wave here, but if you look carefully, you can see that there is some concavity of the PR segment as well as the sloping of the ST segment. So you can imagine that there is a negative TA wave within the PR segment, QRS complex and the ST segment. So this J-point depression of ST segment is partly contributed by the negative TA wave, atrial repolarization wave, which is not obvious in the surface ECG. And after that you go for the QRS complex. Normal width of the QRS complex will be 110 milliseconds or lesser, that is less than 2.5 divisions. It is simple to identify a normal QRS axis because if it is positive in lead 1 as well in AVF, it is a normal QRS axis. In abnormal QRS axis, either one will be different. If it is right axis deviation, lead 1 will be negative. If it is left axis deviation, AVF will be negative. If both are negative, then it will be called indeterminate or northwest axis. And after the QRS, you look at the QRS patterns, whether there is an abnormal pattern, which will be either RSR pattern, QR pattern. Such patterns can be looked at. If there is a pathological Q wave, initial Q wave which is more than 25% of the ensuing R wave and width of at least 40 millisecond, then it is called pathological Q wave. An initial negative deflection is known as Q wave. A deflection which is positive after the Q wave is called as R wave. And even if there is no Q wave, first positive deflection is R wave. A negative deflection coming after a positive deflection, that will be the S wave. So here the Q is not very prominent. Here there is a microscopic Q wave, R wave and a tiny S wave. Here there is a fairly bigger R wave and there is a S wave. This will not be called Q because even though this is the first negative wave, this is coming after a positive wave. Then it will be called as S wave only, not Q wave. So we look for pathological Q waves, abnormal patterns like the M pattern in LBBB, RSR pattern in RBBB. Such patterns we look at. After that we will move to the ST segment. Here you can see the slight ST depression at the J point with upsloping ST. This is a normal pattern. This pattern is due to the presence of the TA wave, atrial repolarization, which is not evident here. And even the ST segment we say as isoelectric, most often it is not isoelectric. It is slowly upsloping and merging into the ascending limb of the T wave. Here you can see a little ST elevation from the about 1 millimeter ST elevation, which is concave upwards. Such ST elevation in V1, V2, V3, all those leads, minimal ST elevation can be normally present. This is not an abnormal ST elevation. This is a normal variant ST elevation in anterior leads. That is why in V2 we need at least 2 millimeter ST elevation, but it is not like that in lateral leads. Lateral leads even 1 millimeter ST elevation is significant. For diagnosis of ST elevation myocardial infarction, in V2 we need at least 2 millimeter of ST elevation. So and ST segment is never truly isoelectric. It is upsloping and merges gradually with the T wave. And this T you can see is a little tall. Such slight tall T waves are also not abnormal. Sometimes it can occur. But if all the T waves are very tall and peaked, then you will think of hyperkalemia, which is one cause for tall peaked T waves. And tall peaked T waves can also occur in hyperacute phase of anterior wall myocardial infarction. Then normally the T in V1 is not very prominent, and there could be T inversions in V1 to V3 normally, but here it is not there. So in some individuals, especially in younger individuals, which is the juvenile pattern persisting. In children, young children, anterior T waves are usually inverted and they can become upright later on, but sometimes it may persist like anterior T inversion in younger individuals. Then you will compare the T waves in V1 and V6. Normally T wave in V6 should be slightly taller than T wave in V1. If it is the other way around, it is also taken as a subtle evidence of ischemia. Another important factor is the normal R wave progression. We can see that there is a R wave here. It is not very tall, but usually it is much lesser, maybe 1 millimeter or so. Here the R wave is slightly taller. And you can see that in V2, it becomes as an RS pattern. This is known as the transition zone, where R becomes dominant. In V1, usually S is more dominant. Here S is almost equal or slightly more. But when it changes to the other pattern, as you go along the chest leads, you can see that R becomes dominant. So the change in pattern is the transition zone. There are certain conditions in which there are early transition and there are late transition also.